Good afternoon, FRT2 class. So today our topic is about pulmonary function test. So what is pulmonary function test? So any idea? So pulmonary function test, in other word or other layman's term, is also called as spirometry test. So spirometry test also refer to pulmonary function test. So the patient is hooked to a computer or a machine called spirometer. So in other institution, we have the higher form of spirometry, which is a body plethysmograph or body box. So in our discussion today, we're only referring or discussing the simple spirometry. So in this subject, we're going to learn to interpret pulmonary test results, identify the normal and abnormal flow volume loops, or the graphical presentation of volume loops of the spirometer, discuss the appropriate monitoring techniques for each procedure and modifications per patient's assessment, like indication of spirometry, the equipment used, hazards and complications of spirometry, monitoring during the procedure, assessment of outcome. We also going to learn to know the purpose and importance of each method used to determine lung capacity, understand the rationale of the safety precautionary measures observed during pulmonary function test procedures, evaluate reliability results and clinical implication during the PFT procedures, and classify all restrictive and obstructive lung disease. So the indication for pulmonary function test, we are considering the indication for medical diagnosis such as determination of the presence of disorder. So ang spirometry or pulmonary functions test is cannot refer to the mere origin or etiology of pathologic cause of pulmonary disability. So it only refers to the airflow restrictions, no, or obstruction. So in other words, PFT refers only to the ventilatory defect per se. So when it only detect patient ventilatory defect, either restrictive or obstructive disability. So you can determine restrictive pulmonary disease and obstructive pulmonary ventilation or ventilatory defect. So hindi siya specific no na pag obstructive ka, you are possible for pulmonary tuberculosis or cystic fibrosis, no, for example, but it only determines the ventilatory defect, so of unknown etiology. So you can relate the etiology of your disease based on your clinical findings. So in other words, to make it simple, PFT can only determine patient ventilatory defect, either restrictive or obstructive. So the determination of the presence of disorder, particularly ventilatory defect. So assessment of degree of which pulmonary function or exercise tolerance is affected by injury of such disease. So determination of pathologic nature of the disease, that is for the higher form, for the helium or the nitrogen dilution. So the specific determination of such pathologic nature of disease or etiology can be specific in your body box or in the higher form of spirometry, such as platismo body box. So, planning of therapy required for treating and management of disorder. So, you need pulmonary function test also. Evaluation of the therapeutic effectiveness of medication of medical interventions such as bronchodilator for disorder. So, what is the rule of bronchodilator therapy against PFT? So, you can determine the reversibility of your bronchodilator. Is a test which is we call the post PFT. The post-PFT test will determine the reversibility of your bronchodilator medication. So in such thing, if the patient responds to the bronchodilator such as salbutamol or Ventolin through what we call pulmonary function test. So dito makikita ang reversibility. So there is a scoring or percentile after after pre-test, magkakaroon ka ng post-test evaluation through PFT. After pre-test mo, you will be inhaling the bronchodilator and then repeat the procedure and then you will see the reversibility of bronchodilator medication of to your PFT results. So monitoring the progression of disorder such as primary pulmonary disorder or neuromuscular. So other indications, we have the surgery-related evaluation is a preoperative risk assessment like anesthesia or surgical procedure. So through PFT, you can determine the tidal volume of your patient prior to surgery. So another indication is a post-operative assessment after surgery of the effect of thoracic surgery. So if there will be a complication after post-thoracic surgery, PFT can determine certain abnormalities for post-operative assessment of your patient post-surgery. No? So this is a surgical-related evaluation. Disability evaluation. We have rehabilitation as a pulmonary rehab. So you can monitor the effects of rehabilitation program. Second is insurance for the documentation of the baseline function of the changes in function, particularly in minors, so for insurance purposes. So we have legal documentation, social security lawsuit, public health research, and epidemiologic survey. So we have the general or specific data accumulation. So contraindication. So first contraindication is hemoptysis of unknown origin or etiology. So hemoptysis is coughing of blood, where hematomesis is vomiting of blood. So don't be confused of the two terminology of between hemoptysis and hematomesis. So hemoptysis is coughing of blood, whereas hematomesis is vomiting of blood. So we have the pneumothorax, other contraindication, unstable cardiovascular status, recent myocardial infarction or heart attack, pulmonary embolus. So that is contraindicated for this procedure. Thoracic abdominal cerebral aneurysm, recent eye surgery due to the increase of what you call is a pressure, you know, so there is will be a possible ocular pressure that can increase through increase also of intracranial pressure or ICP. For ophthalmology case, so there is a possible that there is an increase on oncotic ocular pressure that is in ophthalmology. So presence of an acute disease process that might interfere the test performance like nausea, vomiting, so it's contraindicated in the test. So recent surgical or surgery thoracic or abdominal for the past 3 months. So if you undergo thoracic or abdominal, it can cause dyspnea or painful breathing. So the procedure is not cannot be tolerated with the patient, so it can be terminated. So there will be a rescheduling of your PFT procedure based on your abdominal or thoracic surgery for past 3 months. Hazards and complications, we have pneumothorax, increased intracranial pressure, syncope, such as dizziness and lightheadedness, chest pain, paroxysmal coughing, contraction of the nosocomial infection, such as pneumonia, PTB, and other infections, oxygen desaturation resulting from interruption of procedure, oxygen therapy, or bronchospasm. So, bronchospasm is correlated to chronic or severe exacerbation due to asthma or asthma attack. So patient assessment pulmonary function test, we have the basic information such as the name of the patient, the age, because as the patient go older, interpolated data is correlated or is adjusted based on the software. So the above 6 years old, different ang lung capacity. The gender also correlate with the lung volume and capacity. Male is as different lung volume and capacity when it comes to interpolated values, no, sa software. So that's in gender, standing height, either be in centimeters or inches, is also correlated to the value in the deriving to the predicted values, because the computer tend to predict the predicted value ideal to such gender, races, or age of individual patient. Iba-iba ang predicted value. So we consider the weight and this is very strict about the race. So the software we're using to be the Asian race or Oriental as a default for Filipino patient. So different because if you're using Caucasians, they have the higher interpolated values in terms of predicted values. So the current diagnosis is also considered for the basic information. So we have the history taking such as personal history, such as allergies. Wait, ayaw mag slide. We also consider for patient assessment as the medication of lung or heart problems, the types of medications, what is the medication for, the dose of medication, the schedule of intake, or time of last dose. So it's very important the schedule of intake prior to the procedure, like for such short-term, a short-acting bronchodilator or short-acting beta agonist. So we consider the 4 hours hold prior to the test. For the long-acting beta agonists such as fluticasone or a steroidal form, we consider to hold the medication for at least 12 hours prior to the test. So we consider also the smoking history of the patient. For example, if the patient is ex-smoker or formerly stopped smoking or ceased smoking, currently smoking, type of tobacco or substance smoke, and the age smoking began. This is for computing for the pack-year history of the patient. So we consider also the patient assessment such as hobbies, involves the use of chemicals, art supply, irritating or poisonous substance, pets, place of or residence, including the chronological history of localities, occupational history of the patient. So it's a chronological history of patient's occupation with description of actual job performed. So patient assessment history of symptom associated with pulmonary disorder. So we have the general survey of the patient, the vital sign, auscultation results, and X-ray or chest X-ray results. So test for pulmonary volumes and ventilation. So this is direct spirometry. So these are the graph of lung volumes and capacities. So from the tidal volume, this is the normal tidal volume, no? So as we breathe in and out during normal activity, this is our tidal volume. So lung volume. So we have four volumes and we have four capacity. So the sum of two or more lung volume is represents the lung capacities. So tidal volume, it is the volume of air inspired and expired during normal breathing. So usually, academically, it's almost 500 ml. So in this area, this is our tidal volume. So inhale, exhale, inhale, exhale. So that is the normal breathing or the normal inspired and expired volume of air during resting period. We have the IRV. We're speaking of the lung volumes, so inspiratory reserve volume. So this is the inspiratory reserve volume from your normal tidal volume when you inspired and expired. So in this area, from the word inspiratory reserve volume on top of your tidal volume, so this is the maximum amount or volume of air that can be inhaled after a normal tidal volume. So usually the amount is 3,100 ml. So this is your IRV, inspiratory reserve volume. So we have our ERV. So we say inhalation when you expired fully, maximally. So at the end of your expiration, this is the maximum amount of air that can be exhaled from the resting expiratory level. So your ERV from here up to here is usually 1,200 mils or 1,200 milliliters. So we have your residual volume. So your residual volume is here after your ERV. So ERV is here. Volume of air remaining in the lungs at the end of maximum expiration. It is usually 1,200 ml. Your IRV. Note, the IRV cannot be expelled. It remains to be your normal PEEP, no? So this is a physiologic PEEP, no? So yung lungs will not collapse or your alveolus will not collapse due to your residual volume. So this is composed of inert gases, of light gases as a nitrogen, argon, helium. So siya hindi siya nagko-collapse because the lungs have the residual volume. So kahit you have performed or uh, forcefully expelled your ERV or expiratory reserve volume, all gases cannot be expelled out of your lungs because these gases are more lighter than oxygen. No, if you review your periodic table of elements in your chemistry, so you can see that there are light gases. Uh, Sila yung gas na lighter that always remained in the alveolus of your lungs. So there is no chances to have an atelectasis or collapse of the alveolus because of the residual volume. So hindi mo siya kaya expel ang residual volume. So we are now on the vital capacity. So it is the volume of air that can be exhaled from the lungs after a maximum inspiration. So your vital capacity is FVC or functional FVC when vital capacity exhaled forcefully. So it's forced vital capacity. Slow vital capacity, it is the vital capacity exhaled slowly. So in PFT, we are utilizing mostly as the using the FVC. So vital capacity is composed of your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. So this is the component of the vital capacity, particularly the force of vital capacity. We have two types of vital capacity. We have the force and slow vital capacity. So the total content of your VC is 4,800 ml. So we have the IC or inspiratory capacity. The inspiratory capacity is the amount of air that can be inhaled from the end of tidal volume. So your IC is composed of inspiratory reserve plus your tidal volume. So inspiratory reserve plus your tidal volume is equivalent to inspiratory capacity. So it is all the content of IC is 3,600 ml. We have the FRC or the functional residual capacity. So ang FRC is composed of your ERV, expiratory reserve volume, plus your residual volume. Yan. So ERV plus your residual volume, it will be your functional residual capacity of FRC. That is almost, the content is 2,400 mils. So that is your FRC. Total ang capacity is the total volumes of the reactor. So it's composed of your ERV plus your tidal volume plus your ERV plus your residual volume. The total content volume of the total ang capacity is 6,000 mils or 6,000 ml. So that is for the lung volume and capacities. So later we're going to discuss after uh, another about the criteria of acceptability. So that is for the next topic. So let's end for this lesson about the total and capacity, the capacity and volumes of the lung. See you on the next discussion.